You are now live.
Okay. Good evening, everyone. Thank you so much for joining us for the Society of Black Colorectal Surgeons webinar series. We have an amazing treat for you tonight. We have a phenomenal speaker, and I'm going to get right to it and introduce her. Just so you know, I am Dr. Lynn O'Connor. I am the program director for the Society of Black Colon and Rectal Surgeons, and we have Jessica Mindsinger with us tonight. And Jessica is a certified medical office manager, a certified medical practice executive, and a fellow in the American College of Medical Practice Executives. She is the president and CEO of Surgical Compensation and Consulting, as a firm believer in the power of data analytics, Jessica empowers physicians to navigate compensation opportunities, negotiate successfully, ensure pay equity, and identify cultural fit. Jessica has an extensive background in surgical practice development, management, physician contracting, compensation analysis, and human resources. Jessica has a deep understanding of the unique and often complex nature of the business side of medicine. And after running a trauma and acute care surgery practice for 10 years, Jessica was inspired to leverage her knowledge and expertise to help physicians negotiate their value throughout every stage of the career. Jessica has spoken extensively around the country, and she's been invited to speak at several venues. She's spoken at professional medical and surgical associations and organizations for medical students, surgeons, and physicians of all specialties. She serves as a panelist for the NGMA. She was invited to speak at the Gynecological Surgical Oncologist Diversity, Equity, Inclusion, and Health Committee as a distinguished speaker. She's spoken for Women in Surgery. Jessica is going to speak tonight about navigating physician compensation, expert negotiation tips and strategies for colorectal surgeons. Jessica, we are so thankful to have you here. Please take it away.
Thank you. What a kind introduction. Thank you so much, and for inviting me to be with you tonight. I'm excited to be here. So, I am, as Lynn said in the introduction, I spend my time and expertise working with physicians on physician compensation, negotiation, analysis. I work with small practices. I work with hospital systems, helping them evaluate and design physician compensation. I'm a consultant with MGMA on their consulting team. So thrilled to be here and really excited to share this with you. So I'm an affiliate member of the American College of Surgeons. I'm a member of the Association of Women Surgeons, and a member of the American Association of Provider Compensation Professionals. So I really enjoy physician compensation, analyzing it, using the data, and thrilled to be here. So we're going to talk about negotiation and how important it is for you, and strategies and tips for being successful in negotiation. So I think it's really important to understand that even in residency, male and female residents that were surveyed in 2019 said that they didn't think they would be offered a fair salary off the bat without having to negotiate. And also, in the next slide, you'll see that they didn't believe that they had the tools to negotiate appropriately. And I found this study so important because, these are physicians just starting their careers, and to feel that you're walking into a new career after all of these years of training and sacrifice and student loans, financial debt, to then walk into your new job not feeling that you have the tools to negotiate, is just, to me, unacceptable, and I work really hard to change that. So why negotiation is important? if it feels to you, whether you're early in your career or you're late, in your career, if it feels like physician compensation is complex, that's because it is. And whether you're just starting out, you need to know that virtually everywhere you go, every hospital system, academic center, private practice, the compensation varies, the methodologies vary. So it is complex. It's not just you. If it feels like there's a lack of transparency around your compensation, that's because there is a lack of transparency often around physician compensation. So your compensation is oftentimes designed based on physician compensation data. And there are several main sources that organizations use to set compensation. Well, oftentimes those organizations don't share that data with you. They tell you what the data is, but the lack of transparency exists. So I want you to know that that's commonplace across the board. We also know that women negotiate less than men, and we have data on that, and it's really important, and it plays an enormous role in compensation for women, for female physicians throughout their careers. So we want to encourage women to negotiate more. I tell the clients that I work with, it's really important to advocate for yourself. There's no one who is going to be a better advocate for you to know more about the value that you bring to the hospital system, that you bring to your practice or the academic center, than you. You know what you do day in and day out for your patients, the research that you do, the procedures that you do. So it's really important to advocate for yourself, because chances are your employers, even your chair, others likely won't do that for you. And I think it's really important to adopt the thought that you can trust what people are saying to you. So if administration says to you, we don't have a pay equity problem here, or you're paid fair market value, it's really important to say, well, I trust what you're saying to me, but I'd like to verify that. I would feel more comfortable if I could verify that. So, you have a choice in this. You have a choice throughout your career to negotiate, to evaluate your compensation to see if it's fair, to bring outside counsel in to do that if necessary. But when you make those choices to negotiate, to advocate for yourself, you will see higher compensation. You will see higher job satisfaction. And the overall impact of that really is better patient care and outcomes, less physician burnout and turnover, which is a huge problem in the healthcare industry today. And you'll have higher productivity and revenue as a result of that. So it's really important to do this. And that requires adopting a negotiation mindset, right? So you need to go into your career and know that at every stage of your career, it's your responsibility to negotiate for yourself, and it's totally appropriate to do that. And part of it is, physicians that I work with often feel uncomfortable about negotiating. Like, I'm afraid that people will be upset if I mention my compensation. I'm afraid there will be retribution. I should be patient focused, not financially focused. But I want you to understand that you are navigating the business of medicine. So it's really important to know that it's okay to focus on your financial well-being and health. And every several years, you need to be doing a compensation review, a productivity review, and make sure that that's in line. And when you know and you leverage your value as a physician, what you're bringing to the table, it's really a rewarding feeling. And when I say to you that you are navigating the business of medicine, I mean this. Healthcare spending in the US makes up almost 20% of our GDP. Healthcare is a massive part of our economy, 4.3 trillion a year in spending. And if we go to the next slide, you're going to see what physicians bring to the table for that. So 2.3 trillion of that is generated by physicians. You are a major a major driver. You're one of the most important assets that we have, um, obviously. And in the business of medicine, you're a huge economic driver. And if you look at the next slide, even individually, what physicians bring to the table, the jobs that you create, the revenue that you produce, it's really impactful. So while you didn't, go into the business side of medicine, you went into patient care. I want you to understand the incredible impact that you have on the system and that you are navigating a business. So having um, negotiation tactics, having that experience, having that mindset is going to serve you well. And it's really interesting because when I present to hospitals and practice administrators, we talk about how important physician retention is. So before the pandemic, typical physician turnover was 6 to 7% a year. In August of 2022, MGMA identified a crisis in healthcare because 40% of physicians had resigned, were retiring early. That is the impact of turnover on our practices and healthcare organizations. And why is that? It's so important because we already have a physician shortage, and that is increasing. Of all of the active physicians, almost 50% are 55 or older. So if we don't retain physicians in the healthcare system, the shortage that we already feel, that we know is going to exacerbate over time, is going to continue to grow. So one of the main reasons that physicians have identified for leaving practices is compensation. So AAMC in their study projects a shortage of about 124,000 physicians. A big part of this is that how many of those physicians are going to reach 65 by the age of 2034. So, and for surgeons, we know that the range of shortage, is 18 to 30,000. Well, and there's some controversy over this. Is that overstated? Is that actually true? But what I find working with clients is that a lot of the physicians I work with really suffer from burnout. They're contemplating retiring early. They're contemplating going to part-time. So all of these things are really going to continue to negatively impact the physician shortage. And these are things we can do something about. And so I want you to know, and part of what we're going to talk about is the leverage that you have with your employers, and using your leverage to negotiate base compensation, your work RVUs, bonuses, retention bonuses, CME time. So identifying what's important to you and working to negotiate that using your particular leverage, really important. So, and if we look at the next slide, it's really important for women in particular to negotiate for themselves. Over the course of a 40-year simulated career, women make 2 million less than men over the course of their careers. A big part of that is negotiating for yourself and asking for compensation increases. And, AAMC did this fantastic study. I think we knew a lot of this, we were seeing a lot of this, but it's really stark in this study. We know that gender was the primary factor driving compensation inequity. Men consistently made more than women, of the same race and ethnicity, and white men made more than everyone. So if you look in the next slide, there are inequities driving this. And what we found too, and I see this with clients that I work with, is that women spend, and this is absolutely true, a disproportionate amount of time doing what I call sort of invisible work. So being asked to serve on committees, being asked to review somebody's proposal, being asked to volunteer their time. And all of that is wonderful and so impactful on the system. But when so many of our compensation plans are driven by productivity, that's time away from increasing your productivity. So it's really important for us to recognize these things. We know that, you know, gender, race, ethnicity uh, drastically impacts compensation. And if the subsequent slides show that as well, I think we know this. The difference is that now we have so much compensation data available to help identify this and remedy this. And what's so great about data is that tells the story, right? So it's not my opinion or your opinion or how someone else feels. The data are the facts, and so I think there really is a way to remedy this and to address it head on. And if you haven't had a chance to look at this study, it's really important. Um, it also, it's also discouraging, and so I think that's why the hope in all of this is the compensation data that we have. So if you keep moving through the slides, we know that gender gaps, and I thought this was pretty fascinating, and I see it with my clients too. About 35% of my clients are men, about 65% are women. Sometimes it's 40-60. But what I find is that men are more comfortable going into a negotiation and just asking for what they want. Women are less comfortable doing that if there's not clarity. If they don't have a clear path of what to ask for, they feel really uncomfortable doing that. The lack of clarity, I think for many of us, is what makes it so difficult and uncomfortable to negotiate. So if you look at the next slide, what Harvard Business Review found was that given the data necessary to negotiate, men and women negotiated successfully and equally. So the ambiguity, the lack of transparency in physician compensation is really, I think, a big part of what's driving the pay disparity. And the clarity diminishes that. So what I aim to provide my clients is clarity. And I wanted you all, I'm sure that many of you have seen this report. It's a little bit old in terms of data that we typically use, but this ASCRS report was fantastic. And I highlighted some of the areas that I thought were important and I wanted you to see. And this is a really good place to start if you're wondering about your own compensation. So what this study found, and this is pretty similar for physicians that I work with, most of you are on a base salary plus an incentive plan, right? Likely RVU incentive. So if you look at the next slide, the number one incentive is based on work RVUs. And then usually there's, quality incentives and, patient satisfaction. But the overwhelming incentive was based on work RVU productivity. So when I say, it's really important to think about all the volunteer work you do, all the extra clinical administrative work that you do, all of that is impacting your compensation because it's impacting your work RVUs, because there are only so many hours in the day that we can all work. So this percentile, total compensation percentile, is very similar to what we use at MGMA. And like I said, this data is slightly old, but it's a great place to start. And these benchmarks are fantastic. I mean, the data we have out there is, base compensation, bonus compensation, work RVUs, regional data, data by state. It's incredible what we can look at. So yeah, this study was great. So it provided compensation per work RVU. And like I said, I mean, I think that study is a great place to start and you all have access to it. In terms of MGMA data, I want to share some of this with you just to give you an idea of what we have. So this is 2022 data. This is for all colon and rectal surgeons. We have really great data for your specialty, and we can drill this down to the 23rd percentile. I mean, it's really fantastic data. So we can look at your work RVUs and say, okay, you're producing in the 75th percentile, but you're being paid in the 25th percentile. There's a disparity here. So we can help you, and I do this with my clients, but we build a case. This is where you are. This is where we think you should be. This is the data that you need to share. And it helps you develop what you want to ask for. So when you go into that negotiation with the clarity of this data, it's really powerful, and it helps you develop your negotiation plan and strategy. And you can see from this data as well that the 3-year trending total compensation for your specialty has gone up, right? So over the last 3 years, it's gone up 4%. And in some years, there's a much larger jump than that. So if you can go back to that previous slide for just a second, I want to show you something. So I recommend to my clients that every 3 years you're doing a compensation review. So if you look at the total compensation in 2020 versus the total compensation in 2022, that's about 18,500. And this is just median compensation. So it differs based on each client and what their productivity and situation is. But just for this exercise, I want you to see that that difference is 18,500. So let's say that you renegotiate in 2022, your pay goes up. Over 3 years, that's almost $56,000 in additional total income to you. And that's really important. That's money that can pay down loans. That's money that can pay down mortgages. That's money that can be invested. So once you have a really clear data picture of where you are, it can be really powerful, positive, and powerful in terms of your financial picture. So then in the next slide, I want to show you that MGMA also has academic data. And hospital systems, academic centers, practices, there are several different data sets. So MGMA, AMGA, AAMC. So your hospital system, your practice may use a different data set. Sometimes they blend data sets, but but we're all pulling from the same surveys. We're all surveying physicians. So the data is usually between all the organizations pretty spot on. But I wanted to show you that with MGMA data, we can pull assistant professor, associate professor, chair, division chair. So this is really, really helpful if you're in academic medicine, as you're navigating through your career. It's really important when you get a faculty rank promotion to get a pay increase. And you can see where there's a pretty big difference. And, let's say that you're paid at the 25th percentile. Maybe you have that nagging feeling, something's not right. I don't think I'm paid fairly. I hear some of my colleagues talking about what they're paid, and I don't think my pay is right. And maybe it turns out that we take a look at it and you're in the 25th percentile, but you're productive, you're a celebrated member of the faculty. If you go back for just a sec. So let's say that you decide to go in and talk with your chair or administration, and you're able to negotiate median compensation from the 25th. That's about $50,000 a year in today's physician compensation, the most recent data we have. So over 3 years, that's like $150,000. So it's worth having these conversations, and it's worth going into these conversations with a clear outline as to where you should be in your compensation. And then if you go to the next slide, this was data that I used. I was consulting for a small practice owner who was looking at hiring in a colon and rectal surgeon. So this person had several different possibilities that they were looking at hiring. One was straight out of fellowship. Another was a more established physician. So what we did is just pulled data for this practice owner to see what the median compensation was for a starting provider. So the first data that's highlighted in green, that's for a starting provider straight out of fellowship. So we looked at general surgery and colon and rectal surgery. And we looked at the median signing bonus. And then we looked for another candidate that they were considering that was a little more experienced. We looked at just physician data across the board. And then we looked at data for that particular state because we knew the cost of living in that state was somewhat higher. And so this is a great way for a practice owner or a practice leader to recruit a new physician into the practice and be able to provide this transparency to that new recruit to say, we're paying the median MGMA, we're really competitive, these are the RVUs that we expect. So this compensation data works, for physicians who are hospital employed, physicians who are practice employed, physicians who own practices, and academic physicians as well. And if you go to the next slide, I often also use AAMC data for academics. And I typically, if I'm working with an academic physician, I'll combine the two. So I'll use MGMA academic data and AAMC. AAMC is fantastic data. It does not provide the RVU data. And but it gives you a great picture for what's happening in academic medicine. And it's also a great backup. It does not have as many of the individual specialties as MGMA or Sullivan-Cotter might, but it's an excellent source, and it's cost effective for physicians to purchase this data and have access to it. And I believe if you're a physician member of AAMC, some of this is very inexpensive and even free to you. So this is very easy, that AAMC data, very easy to navigate. I really, really like it. But I'll tell you something just really quickly. I recently did a consulting engagement with a department at an academic center. So the chair hired me to review data. It was a small department, 5 physicians. And she said, the hospital's been really great. They're very transparent, and they've shared with us that they use AAMC data and they use MGMA work RVU data. She said, so we're really grateful. The hospital's really transparent about that. Well, we took a look at that data, and what I found was, yes, they were really transparent, but they were using data that was 3 or 4 years old. So this chair was having a really hard time staying competitive, bringing people into the department and keeping people in the department, because the data that they were provided just wasn't up to date. So they weren't as competitive. So, when you're in the process of negotiating and you talk to, your chair or administrators or the practice owner, you want to know what data they're using and how recent that data is, because we know when we look at the trending data how much that changes. Really, really important. And then if you move to the next slide, I really want to stress this to you. I really want you to consider how when somebody asks you to be on a committee, to serve on a board, to review research, to review grants, to take on additional administrative duties, I really want you to think about how that's going to affect your productivity, even if that's by 10%. You could miss your RVU threshold because of that. You could miss a bonus opportunity because of that. So please be aware of that. And if there are shifts in your administrative time, then say, I would be happy to serve on this committee. I would be happy to do this work, but I'm going to need you to take my FTE down to 0.8 or 0.9. And that will drop your RVU threshold, should drop your work RVU threshold accordingly. So just keep that in mind as you're navigating through your career, and really protect your productivity time. And if not, have them offset it for you. So tips that I really want to stress to you. I want you to negotiate at every stage of your career. I work with a lot of fellows who are just finishing up fellowship and reviewing offers and getting ready to enter into their first job. I absolutely love that work. You can make such a big impact. But regardless of where you are, your first job, early in your career, mid career, late career, I want you to negotiate. And I want you to be comfortable asking for what you need. And that means, if I had a physician that I worked with who was negotiating a compensation update, but she also had a child with special needs, and she needed one afternoon a week off, and that meant flipping a clinic to a different day. And it was just something that was so important to her and so meaningful to her, so she could have that time with her child. And so, we were able to put that into words and to make a compelling case, and she was able to negotiate for that. But her priorities once she was mid-career with children was different than when she started her career. And so I want you to, at every stage of your career, I want you to think about negotiating and using your leverage to ensure that you have a fair contract. And it's not just always about money. It can also be about CME time. It can be about research time. It can be, a scribe that makes your productivity better and your day better. It can be less administrative time. Whatever it is that you need to be successful, it's really important to ask for that. I also want you to know your numbers. And what I mean by that is I want you to know your compensation. You should know where your compensation falls in terms of, are you at the median? Are you at the 75th percentile? Are you at the 25th percentile and you need to negotiate? You need to know that. You need to know your work RVU numbers, and you need to track your cases. Oftentimes, I work with physicians who find that when they get a work RVU report, things are left off, cases aren't covered. It's really important for you to track your cases, and that also helps you make the case about your value to the system. When you know that you're generating funds, hospital fees, operating fees, you're supporting, a whole team in the OR, that's really important numbers to know, because that's part of your leverage when you go to the negotiation table. And that's really, nobody is going to track that more consistently, more accurately than you will. So it's really important to know your numbers. You're a valuable, incredibly valuable member of your system, of your team. And it's okay to have to have confident humility, to know your power, and what you bring to the table, and to ask for what you deserve in return for that. And finally, I want you to review your compensation routinely. And I mean every 3 years. I wouldn't let it go past that, because things change. I've had clients who are highly esteemed physicians, department chairs, who've been with a system for 25 or 30 years, and they realize that they are hiring new physicians in, they're recruiting new physicians to their team at a higher compensation than they're paid. And that's because they didn't routinely review their compensation and negotiate. And I think part of it is sometimes people feel like, well, the hospital will take care of me, or the practice will take care of me. So it's really important to understand that that may not be the case. Hospital administrators come and go, chairs come and go, practice leaders come and go. But this is your career and this is your value. And it's really important to advocate for yourself routinely. And when you do that, I know that it can feel like negotiation means confrontation, but it absolutely does not have to. And when you're armed with accurate data, it can be a really proactive process. And when you walk into work and you know that you are paid fairly, you feel respected, you feel heard. And like I said, it may not just be compensation. It may be other parts of your of your contract that are specific to your particular situation. It may be that you need to work 4 days a week. It may be that instead of retiring, you want to work 3 days a week. Whatever it is that's important to you, when you feel heard, when you have advocated for yourself, I see this happen. You will show up in the fullness of your own power, and it's just an incredibly positive thing. And it doesn't happen if you don't negotiate for yourself. And you'll also live with less self-doubt. And, part of what's so great about looking at the data that's applicable to you for your specialty in your region, in your career stage, is that you don't have to wonder, is there a pay disparity? Am I being fairly paid? Is it okay to ask for this? Reducing or eliminating that doubt is really, really impactful. And I think it reduces burnout and turnover. I see it. I tell whenever I'm presenting to hospitals, to medical management professionals, I stress this over and over, how important it is to reduce physician burnout and turnover. And it's really more than it's not just the compensation, it's the feeling of fairness, of respect, of stability. And those go a long way to ensuring that you're happy and satisfied in your career. And that kind of collaborative negotiation can lead to a really fulfilling work experience. And there's just, and and better patient outcomes. You're not burned out. You don't want to leave. So it's incredibly important. And other physicians will see you advocating for yourself, and they will do the same. So you're paving the way for yourself, and you're paving the way for others to follow. And it really comes down to this: you're not going to get what you don't ask for. It's very rare that administration is going to come to you or your chair is going to come to you and say, I want to give you a raise. And if they do, wonderful. If not, it's okay to ask, and you're likely not to get it if you don't ask for it. So I can't wait to answer some questions, and thrilled to be here. If you have other questions after this, feel free to reach out to me. Absolutely.
Jessica, thank you so much. The
Yeah.
chat is just full of questions
Oh,
for
good.
you. That was so informative, and that's something we really, really need to hear. And like you said, that was so key to review your compensation.
Yeah.
Every 3 years. How many times do we don't do that? Um, so I'm going to get back into some of these questions. They're flying in. Um, can you speak to the pay differentials that exist in underrepresented minority groups?
Yeah.
And do you have any comment on what we call the minority tax? Are you familiar with the minority tax?
Yes. Yes. So I think that the data is the answer. So it's really, if you know that in your particular situation that you are generating, you're incredibly productive and you're generating RVUs in the 65th percentile, and we look at your compensation, or you get the data and look at your compensation, and you see that you're paid in the 25th percentile or the 40th percentile, it is absolutely imperative to remedy that. And I think that's where the data makes such an enormous difference, because it's really hard for an employer, for an administrator, to deny that when the data is right there. Everybody should be making the same. This exposes the pay disparity and it helps remedy it. And there are times when I have clients who go through this process and an administration won't make a change or won't acknowledge that there's a pay disparity. And at that point in time, it's up to you to decide, do I want to stay here? Is this an organization I want to be a part of? Or do I need to leave and go somewhere where they have proactive pay equity audits, where they listen to me if I have a concern, and they listen to me with respect, and they are active about remedying that? The best systems, the highest performing systems, are the systems that do this routinely without having to be called to account by their physicians. Those are the systems that update every year, that update every time somebody gets a promotion, that, every time there's a bonus, there's not a, I had a physician who was a female who was not provided the same pay increase that the other four male members on her team were provided. It was um, such a blatant case of discrimination. She took that data to the hospital. Not only did they give her the back pay and remedy that, but we were able to negotiate interest on that because of the delay of when she should be paid. So it was 2.5 years that she waited to be paid commensurate with her male counterparts. So once she took that data to the administrators, it was really, they had no choice but to follow through on remedying that. So I just feel like the data, which is what physician compensation is based on, the data is the answer. And it's regardless of your color, of your gender, of your age, the data is the answer.
Now, I have to piggyback on that. Did that physician require a lawyer? Were they able to do it on their own? Was there someone to advocate for them? Because
Right,
oftentimes, if you're young, you're first starting out, you don't want to ripple the waves, or even if you're mid-career, you might be scared to push this. So,
right.
how did that work out? Were they empowered? Did they have a lawyer, or how did that work?
We worked together and came up with a very compelling data and the financials for her. She was able to take that to the hospital. They knew she was working with someone who was a consultant and an MGMA consultant. She just had them dead to rights, and they paid it, and then they paid interest on top of that. So her next step would have been going to a lawyer, and I would have worked with her to be an expert for her. But it was so, you know, I think that's, and what I'm hoping and what I work with MGMA on and push with MGMA is to make this data more accessible so that physicians can more easily identify this. Because when you're using this compensation data, you're talking their language. So this is the data that they use to ensure that they're meeting fair market value and commercial reasonableness. So you probably have heard, hospitals or employers say that to you. Well, your pay is fair market value. Well, what does that mean to me? I need you to show that to me so I can see it for myself. And fair market value could be anywhere from 10th percentile to the 75th percentile. So that's a really big range. So I just think to stop the pay equity gap, the more we can have transparency and clarity, the more we can get this data out there, the more empowered physicians, of all colors, of all ethnicities, of all genders, will be successful.
So, how do we get access to this MGMA data?
So you can buy it from them for your particular specialty. The trouble with the data is it's hard to use, and there's a lot of training that goes into using it effectively. So if it depending on where you are, you may need someone to help you pull the specific data and benchmarks and help you interpret that and build a case. But there's a lot of data, if you're in academics, that AAMC data is a fantastic place to start. Hopefully, you'll have a chair. The chair that I worked with recently for their department, that was just a fantastic experience for that department. For me, we were really successful with it. But so hopefully you'll have a chair, you'll have administrators that are willing to share that data, and I would push on that. And you don't have to be nasty about it, but it's just reasonable. It's reasonable to say, I appreciate that you're using compensation data. I would like to see what you're using for me. I would like to see my benchmarks. And hopefully they will be amenable to that and cooperative and work with you on it. If not, you may need to go find some additional help. But there are people out there, I do this, there are other people who do this. And it's extremely powerful.
Jessica, is that data free? One of the members want to know. Because
The MGMA data is not free. We're working at, they just started, I really, really pushed for this. So they just started giving out data to individual physicians. I think it's $500 to $750. It's your specialty and it's just the raw data. The AAMC data, I believe it's free for if you're a physician member, and that's a great place to start. I know the American College of Surgeons has some basic data available that you can pull. So, when I'm working with clients, we're typically, I've at times worked with clients that are above the 90th percentile and, want to keep that. And we're trying to figure out if we can make a case for fair market value. And then I have other physicians who just have tried everything else and they just aren't able to negotiate what they need. And we come up with the analysis and the strategies to do that. So it's not easy, and they don't make it easy. And that's really how I became a member of MGMA. I was negotiating with administration on behalf of the practice I was leading, and the hospital wouldn't provide the data to me. So they were setting our call coverage pay based on Sullivan-Cotter data, but they wouldn't show it to me. And the administrator said to me, go get your own data. And she showed me the door. And so I went back to my office and I recognized that this was, 15 years ago. In order to do my fiduciary duty for the practice, I had to have my own data, I had to educate myself, and I had to be able to go in there and negotiate effectively. And that's what I did. And that's the day I became a member of MGMA. And I've gone through, the credentialing and training since then and started my own practice. So my own consulting practice.
so,
So
yeah, you've given us an idea as a society what we may need to do on our own as well.
that's right.
Um, there is a question in the chat. Is there a difference in RVU value between colorectal surgery and general surgery?
Yes, there absolutely is. And if I don't know if we can go back in the slides, I don't know if I pulled that or not. There absolutely is. And that's important to know too, because there are times when I have seen, let's see, if you keep going, next few slides. Did I don't think, let's see, here I did. If you go to the, yeah, I don't think I pulled that for this, but yes, there's a difference. And what you'll find is that there are times when the hospital, and I've seen this, will use general surgery data, RVUs, total compensation, if it's lower in a certain case than the specialty. So that happens oftentimes with breast surgeons. So that's really important to know. That's a really good question. And you want to know not only what data they're using, but what specialty they're pulling. And if there's not data for a particular specialty, oftentimes they'll use a roll-up category. Well, the more information you have about that, the better, because then we can drill down into that to compare and sort of keep them honest. So if the person who asked about that, if we have their email address, or I'm happy to send them that data. But yeah, there's a difference between general surgery and colon rectal surgery.
Thank you. Yeah, that's one of our members, and we'll definitely get everyone. You'll be able to get in contact with them. I'm sure at the end we'll have your slide back up again because everyone it's chock full of questions.
Good.
There's another question: is how do you start negotiations without being confrontational?
I think it's just really reasonable, especially think this is a great way to bring up compensation. So let's say that you started a position, it was a 2-year contract, and it auto renews at the end of that 2 years, right? Well, the auto renewal is a really easy way to sort of get caught in the system and not do a compensation review. So at the end of that 2 years before the renewal, it's really important to go to administration or your team leader, whoever that person is, that department is, and to say, my contract is getting ready to auto renew. I'd like to do a compensation review. So I'd like to know, where my RVUs, what percentile my RVUs are I'd like to know what percentile my compensation is, and I'd like to review it and have an update. And that is a great way to start the conversation, and it's totally reasonable. And they're likely not going to come to you before renewal and say something unless you're underperforming, at which point they will come talk to you. If you're performing or overperforming, they won't. And it's really important to think about how, just think about inflation over the last 5 years, what's happened to inflation. So if you're being paid at the same rate that you were 5 years ago, and inflation has changed this drastically, your cost of living is so much higher and your pay stayed the same. So you don't have to be confrontational about it. You just need to say, hey, you know what? It's time for a compensation review, and I'm going to do this every 2 or 3 years. And hopefully, and they should be cooperative. It's totally reasonable. People in the corporate world do this all the time, and they have a lot more transparency when they go to negotiate.
Thank you for that. There's another question in the chat. We have a lot of young surgeons on,
Yep.
and they want you to talk about. Can you just basically explain what an RVU is and how they work? We've got
So
a
it's
lot of residents as well too.
Yes, it's a productivity measure, right? So it's supposed to be an equalizing thing. Each procedure has a certain number of RVUs assigned to it, and so it's a measure of your productivity. But it drives so much of your compensation. It's really important to understand this. I have physicians who were just out of fellowship, right? And they signed a 3-year contract. They had a guaranteed base in those first 3 years, so they had guaranteed compensation. At the end of that third year, their compensation flipped 100% to productivity. So it was 100% work RVU based. Well, a lot of things can affect your productivity. So if your anesthesiologists go on strike and the ORs shut down, that affects your productivity. If you don't have OR block time, which is a huge issue for a lot of physicians, that can affect your productivity. So it's so important to understand what's going to happen to your compensation, especially early in your career, and how impactful those are. And you have to understand too that your work RVUs oftentimes are impacted by, I have physicians who are relegated to first assist for a really long time so that their senior partners get the bulk of the RVUs for procedures, and they don't. And then that they get to the end of their 3-year contract and they have a real problem because their RVUs are not really reflective of what they're giving to the system. So I really encourage you to understand those, to track those, and to protect your productivity time. And I would be really wary about entering into a contract that's 100% productivity, or a contract that's guaranteed and then flips into 100% productivity. There's just so much that's out of your control. It can really affect your compensation.
Jessica, we have another fellow on who has a question about they're going into their first negotiation. They're finishing their colorectal fellowship.
Okay.
They're being advised that their leverage at this time is the lowest. So, what areas in negotiation do you recommend for new attendings? Is it base pay, RVU targets, or is it more a personal decision?
I don't think their leverage is at the lowest by any means. And I don't, that's not where I see the data. The data doesn't indicate that. And I don't want you to go into a negotiation feeling that way. So it's really important, the fellows that I work with, it's really important to identify what is most important to you. I have fellows that the most important thing to them is research and protected research time. So, they want to be paid fairly, but they know their pay may be a little lower because the goal is the research and that protected time. So, areas for negotiation are areas that are important to you, number one. And then number two, that base pay. At times, that base pay can be negotiated. It depends on, the academic center. Sometimes those are set. Your work RVU can be negotiated. Your signing bonus can be negotiated. And a lot of times, and even chairs will tell you that if you don't ask for it, they may not give, they're not going to put a signing bonus on the table if you don't ask for it. Ask for a signing bonus, ask for relocation expenses. Um, a lot of, oftentimes, it's really important to ensure that you have enough time for CME, especially if you're research focused. You're going to be presenting, you might be part of a society where you want to be highly involved. You may need 2 weeks of paid CME time. And especially when you're just starting and you're dealing with all of the student loans, you know, paying for that yourself can be really cost prohibitive. So if that's a priority to you, ask for it. You may not get all of this, but you may get some of it. And it's just really important to know you didn't leave those things on the table. Another thing that we're seeing more and more often is tuition payments, tuition reimbursement. So it's certainly something to ask for. It's a large part of recruiting incentives now. So just, those are all things that are on the table, and I would certainly ask about them.
Jessica, we have like 3 minutes left, and there's one other question here that I think Dr. Tranchu would like to know if you can comment on the data available on Resolve.
Data available on Resolve. So I think they use MGMA data. I think they give you you pay for it, and then they share some of the MGMA data. So I think it just, and I don't know if they're an MGMA member or not. So it's really going to depend on how, it may be that you have data from a certain source and all you need is that number and administration is going to work with you. Or just sometimes, depending on how, your circumstance, you just may need more consulting than that, more in-depth data than that, and specific recommendations. So there are companies out there that provide sort of bits and pieces of the data. And it just depends on how personal how much personal data and analytics you need to get, to get to the highest and best contract that you can get to.
Jessica, I'm going to squeeze one more question in.
Okay.
Any comment on private practice owners with negotiation with insurance companies on reimbursement?
Yeah, that is really, really tough. And I think that is why, I know that is one of the key factors in practices being bought up by hospitals and people not wanting to stay in private practice. It's a really tough landscape. And part of it is having the right person on your team to negotiate with those companies for the highest and best rates. And that's something that's it's sort of like a compensation review. Those contracts have to be analyzed and negotiated every year. And it's the same thing in terms of using your leverage with those insurance companies. And that's really where you have to have that key person in your practice, or an outside, third party company that can help you negotiate that, because that's key to, private practice survival. Absolutely.
How would you recommend just having a outside person come in and audit and work with them?
At times, yeah, that can be the case, or it can be, that you have a person on staff who's trained and really great at doing that. That is just an ongoing, that's an ongoing project for sure. And there are consultants. I know we have consultants at MGMA that do nothing but that. That's their expertise. So in order for private practices to stay viable and really to want to stay in private practice, that's a key practice indicator, and you may absolutely need outside help or the right person on the inside to negotiate that.
Jessica, thank you so much. We're going to have to invite you back because there are more questions than we have for time here.
I was
But
so happy to be
we
here with you. Thank you so much.
definitely make sure we have all of your information provided to our members, and they will be reaching out, I'm sure. And we'll make sure that you're able to contact them as well, too. Thank you again for all of your time. And members, stay tuned for our next webinar coming up in April. You'll hear more information about that as well too.